to make it sexy. Epilepsy is a really horrific condition, and there is a lot of doom and gloom associated with it. Understandably, we need that understanding. We need you to understand us.
Today, I'm joined by intellectual disabilities nurse and epilepsy champion, Jay Price, who's going to be sharing with us why epilepsy is still being overlooked across funding, policy, and care. We're going to talk about why epilepsy still receives disproportionately low attention and funding, how public and professional understanding is often narrowed to tonic-clonic seizures, and why improved education and co-produced training could improve quality of life across the epilepsies. If you're new here, please subscribe so that you don't miss future conversations. And let's get into today's episode, presented in partnership with Easy by Prosthesis GmbH. So your paper is titled Epilepsy. It's just not sexy, is it? What does this mean when you look at funding and attention?
My paper really focuses on the lack of understanding and awareness out there, and the lack of perception that we have within epilepsy. So when we're talking about resources and funding from government or even charity or even health research, it is very much pushed to the bottom of the pile. You know, more things such as diabetes or cancer or heart disease is prioritised because of the health priorities within England, whereas neurological, especially epilepsy, is just not focused on as much. And we see that in disproportionate of services throughout the United Kingdom and Ireland, that actually you could go over borders and things such as from Cornwall to Devon and the services aren't the same. So yeah, it's quite different. So when we're talking about like the funding side of things, the Epilepsy Research Institute actually came across with the funding of in research. Epilepsy received 0.3% of the 4.8 billion that health research went into, which is actually phenomenal if we're talking about it. So when we break that down a little bit further, just for different diagnoses, 82.5 million of that went into dementia, 34 million went into Parkinson's, but 12.8 went into epilepsy. And then when we break that down further into how much was invested per person with those diagnoses, £234 per person for Parkinson's, £97 per person for dementia, and only 21 per person with epilepsy. So actually, when we look at it, that the funding's just not there. It's just not recognised. It's not sexy.
What does this tell us about epilepsy is prioritised or is not prioritised within healthcare and research and policy as well?
I think it's really hard for policymakers, commissioners and things like that to prioritise epilepsy when there is the epilepsy community and the epilepsy needs are so diverse. So you can't put it into just one pocket of let's reduce SUDEP, or let's put more funding into the different types of epilepsy or genetic screening and things like that. We can't put it into one aspect without impacting the rest. So if we prioritise one part of epilepsy over another, then we're creating that kind of a hierarchical position within the condition as well.
There does actually seem to be quite a bit of competition, I would say, even between different sorts of epilepsies and different symptoms of the epilepsies as well. Would you agree?
Yes. I mean, this is something that I've recently been aware of, but I think media plays into a role of this as well. You know, that if a person has tonic-clonic seizures, for instance, it's more sexy in a way because you can visualize it. They are risky in terms of medical emergencies. However, people who experience focal seizures, you know, don't get the same recognition. Media doesn't recognize that. It's not seen or recognised as much, and people don't understand that aspect of it, that epilepsy isn't just tonic-clonic seizures, you know, falling down, having a frothing at your mouth, wetting yourself or soiling yourself, and convulsing. There are multiple aspects of seizures. And not only that, though, that seizures are just a tiny perspective of the iceberg, really, really tiny perspective, where there is so much more that the condition impacts the person.
Yeah, exactly. And I think those other symptoms are rarely seen by the general public, but even amongst many people with an epilepsy and by carers, in fact, and often not focused on. And we can't expect the rest of the world to change if we, people with an epilepsy and carers, and sometimes, unfortunately, often clinicians too, don't see past seizure activity and see past generalized seizures, which, and that's it's crazy in itself, because only half of patients with an epilepsy experience generalized seizures. So why are we chopping out half the population?
Absolutely. And what about those people that don't present in a perfect way for epilepsy? The people that are still going through diagnosis, and especially in the intellectual disability population, we have such an abstract view of seizures, because we have people with cerebral palsy, we have autistic people, we have people with intellectual disabilities, and people that encompass all of those conditions, and they have very stereotypical behaviours, they have repetitive behaviours, and the misdiagnosis is approximately, I believe, a third, that they're misdiagnosed to have epilepsy or misdiagnosed not to have epilepsy. And actually, we're not focusing on that element either. Like, there are people out there that have strange and obscure seizures that just don't present in the normal fashion. Like, I used to work with a lady who used to strip during a seizure, but she would strip to induce a seizure and then strip during a seizure. And it was kind of like, well, are you inducing, or are you actually in a seizure right now? Like, I don't know.
But I have stripped. Well, only one time I know that I started stripping in a seizure years ago. And I only know because when I came to, and oh my God, the headache. But I had to ask my colleagues, why have you put a tea towel over my groin area? And she said, mate, because you were stripping. And I learned you have to wear nice underwear if you have epilepsy. I didn't that day, and that was the worst thing.
Promote that.
Yeah. Make sure you have nice undies on. But anyway, but in all seriousness, these are things that people experience, and we can go back to your whole thing about an iceberg, or inferring that you have an iceberg. You see the top of the thing, but mate, if you come at it like the Titanic, you're going to soon realise what the awfulness underneath the surface level shows, and we need people to realise that. Tell us about your co-produced training. What needs to change in how we train health and social care professionals to better support groups? And I would add to that as well, how we need to better train people and with an epilepsy and their carers.
I think there could be a lot of improvement within this sector. I think that the most important thing we need to start doing as clinicians, as people in general, we need to start listening, and not just listening of, yeah, I understand that. No, genuinely listening, and listening to not to resolve, but to listen and hear what that person is saying. And, a person comes into clinic and you're talking to them about their seizures. That's great. But actually, what they may have just happened is they couldn't go out with their friends because they had a horrific seizure and they felt exhausted afterwards. They're not sleeping because they're paranoid about having seizures during the night. They can't drive, so they've lost their job. Why are we not looking at all of those elements and just focusing on the seizures? So I think that we need to start hearing people and hearing people's what people want everybody else to know about epilepsy, not just seizures and medication and treatment.
Also, I think you can add to that as well. Like, for instance, you spoke about going out. People are worried about going out because they might seize, but often people are worried about going out or feel they can't go out because they're so depressed or because they're so anxious, which is often a symptom of the epileptogenesis as well.
Yeah, but we don't talk about that. Because, and I think this is where the disparity comes in. We are all taught as health and social care practitioners to be holistic and person-centred, but actually we have so limited time to do that we are focusing on what we need to focus on right now. So I'm a learning disability nurse. I focus on the whole person. However, if I'm going out to do a behavioural referral, not everybody will talk about the wider aspect of the behaviour, like, do they have epilepsy? Is the epilepsy very interlinked with the behaviour? What about constipation? What about, daily activities? And we're not talking about that. And from an epilepsy point of view, you go into a clinician, they're talking to you about your seizures. They don't want to know from the anxiety point of view because that's not their role. But why isn't it their role? You are an epilepsy practitioner, and epilepsy is much more than a seizure.
It is their responsibility to look at these other things. But just so I suppose we don't have anybody listening who has an epilepsy to freak out immediately at any clinician. Clinicians often don't have the time literally to go into anything else. And this is wrong, but it's not their fault. And so we need to be working together, I would say, people affected by the epilepsies and all different types as well, not just the individual specific diagnosis, with clinicians and with researchers, rather than as separate entities trying to, where it appears that we're fighting for different things, when in fact we are all here to try and improve quality of life.
Absolutely. And, practitioners, health and social care practitioners, they are professionals in their own right, but they are people at the end of the day. They don't not care. They're not deliberately not giving you that time. They're just not given the resource to do that. And if we involve people and co-produce research and co-produce training programs to better the lives of so many people, it's not just going to impact people with intellectual disabilities from my research. It's going to impact children. It's going to impact adolescents. It's going to impact young people and adults and the older generation. It's going to impact everybody because we're involving the main stakeholders. We're not just health and social care professionals or funding authorities doing this research because we're trying to tick a box. We actually want to hear and improve things for you. It's not for us, it's for you at the end of the day.
Before we move on, with thanks to Easy by Prosthesis GmbH. How do we achieve that?
We need to make it sexy. Epilepsy is a really horrific condition, and there is a lot of doom and gloom associated with it. Understandably, we need that understanding. We need you to understand us. For people that this condition is often debilitating, we need to look at presenting it in a way of, we know it's difficult, we know it can be difficult, but in order for us to get better, we need that understanding. We can lead really meaningful lives too, in a sense of, you can get married, you can start a family, epilepsy doesn't have to define you.
And we need to communicate that to other people, I think, and perhaps be less almost segregated into our little sections and maybe come together as one, as other diseases have done very well, like cancer, like Huntington's, like multiple sclerosis, like Parkinson's. I mean, admiration marketing wise, darlings. I just think,
let's take some inspiration from them. They are doing fantastically well to promote their conditions and to, the people running for London marathons and things for Stroke Association or Parkinson's Association or even Mind, the mental health charity. I think there is so much value in that promotion, but it starts from the bottom. We need to employ and encourage the people that are experiencing this on a day-to-day basis to get their voices heard.
And to do that, they need to be educated regarding the disease, not just how it affects them, but how it affects everybody else, and have the confidence to speak openly and in an educational manner about it, as many people affected do already, but I would potentially not enough, and not as many compared to these other previously mentioned diseases.
The stereotype of epilepsy is, like I said before, falling down and having a tonic-clonic seizure and frothing at the mouth and wetting yourself and things like that. Whereas actually there is much more to a seizure. And actually, if you were to be diagnosed with epilepsy, you don't have that knowledge in a 10, 15-minute appointment. So then you go searching for that knowledge, and sometimes you fall upon incorrect resources or...
You're so polite. Let's face it, there is a lot of rude wordness out there, but it's so easy to fall into that hole and that echo chamber. But I guess that's where some of the charities can be amazing with that, to actually give you, or Epilepsy Sparks, one might think, to give you credible information based upon empirical evidence, not something that's just all like woo-woo, some random thing from social media that might not be true.
Absolutely. And I think like that goes into the cycle of the fear and the scaremongering. Like there is such delivery of like scaremongering within the epilepsy population that, you know, you type in a seizure and it's like, you could die. Okay, but we could die from anything tomorrow. Like there's a meningitis scandal currently going around. Like we could die of meningitis, but you can absolutely die from epilepsy. I'm not negating that, but that's not what we should be presenting to people. Like that is not the most paramount thing.
It's quality of life. And so education of all parties, and let's work together and make epilepsy as sexy as the other diseases. Marketing. This is marketing speak. We're not saying, oh, darling, ding dong, epilepsy. We're not saying that.
Absolutely not. Like, if we were to dress it up in like lingerie or anything like that, I think the best thing that I would say to people is we need to talk to one another. We need to hear each other's voices, and we need to hear those experience. And how can we promote these training programs and deliver training programs if we're just talking about it from a clinician point of view? That's why co-produced research and co-produced delivery is so vital here. You shouldn't do research just to tick a box. You should do research in these areas to raise questions. Like maybe you have found or identified a question that nobody has ever thought of within that population. You know, have we ever thought of teaching commissioners about epilepsy awareness training? How can they make decisions about epilepsy funding if they don't have the knowledge and understanding about epilepsy in the first place? You know, have we thought about that? Have we thought about how it's regulated within services and things like that? But not only that, like the voices within that research, especially qualitative research, you know, those voices are so paramount. Like I can analyze until the cows come home, basically, of all of that, but you are talking to an individual that has so much insight or so much knowledge that you can't even touch upon or learn in like a day-to-day basis. You learn from each other.
Thank you so much to Jay for sharing her paper and highlighting how improved education of all parties, improved awareness, improved training and joined up advocacy are all essential if care and outcomes are going to improve. Again, huge thanks to Easy by Prosthesis GmbH for partnering with Epilepsy Sparks.